Good morning, and thank you very much for joining us today. Thank you for your interest in today's webinar, Prevalence of SUD in the Asian region over the 2-decade perspective, New Tendencies and New Substances. And speakers from different parts of the Asian region, Thailand, Indonesia, Kazakhstan, Pakistan, Philippines, and India, will present you with various epidemiological data. Our webinar is happening with the support of ISSUP, the International Society of Substance Use Professionals, the membership organization with more than 15,000 members globally. And ISSUP supports the building of the workforce all over the world through the national chapters and events. And we invite all of you to become ISSUP members if you are not already, so you could become a part of our group. For more information on the membership, please visit our website where you can find the membership application form. Links for the website and application form please find in the chat. So let's move on to our presentation, and after the presentation we will have a short Q&A session. And if you have any questions, please send us in the chat during the presentation. You can find chat in the GoToWebinar control panel. And now I would like to introduce our first panelist, Dr. Prapapun Chucharoen, a Program Director of Master of Arts in Addiction Studies, Asian Institute of Health Development, Mahidol University, Thailand. She is a director of Asian Pacific Regional Collaboration Center of International Consortium University for Drug Demand Reduction and Board of Directors of ICUDDR. Dr. Prapapun was recently appointed to the Columbus Plan ICCA Commission and serves as the education provider and lead of Asia Pacific Regional Collaboration Center of ICUDDR. Dr. Prapapun Chucharoen, thank you for joining us today. We greatly appreciate, and I hand over to you.
Thank you. Okay, I will show my screen. Okay, moment. Okay, thank you very much, Dr. Ho Ha. I hope everyone hear me. My name is Prapapun from Bangkok. Right now, I finished my round of program director. We at Mahidol University we have a new program director. She is Assistant Professor Dr. Bang on Tien. She is the new program director. Okay, and let me start my presentation today. Okay, I hope everyone see my presentation. Okay, oops. Okay. Today I will talk about the 2 decades of ASEAN drug use and monitoring report. This is a preliminary data that we found during the 2 decades in ASEAN. And for today, I have around 15 minutes talking, so I will wrap and brief about the rationale and background, key finding during 2 decades, and conclusion with the big challenge or gap and research opportunity in research. This is a rationale and background for the 2 decades that we know about drug abuse is a major health and social problem. And from the previous studies show that this is a major problem throughout the world. although drug trends may differ from region to region, and drug cross-claim, illness, violence, and death. This is the that I catch up from the 2 decades. And for the report of UNODC on 2004, we found the total number of drug users around 185 million people who drug use, and the major age group are over 15 to 64 years. This is a major problem of the drug in the world. The red one is opiate, and the yellow one is cannabis. It is very little alphabet, okay. And the green one is the green one is cocaine, and the blue one is amphetamine, and the other is the gray one. This is the main problem of World Drug Report since 2004. Whereas I try to combine the 3 years of the 2001, 2002 at the blue one, and the red one is 2003 plus 2004, and the yellow one is 2005. I try to combine the cannabis among 3 years, amphetamine among 5 years. I'm sorry, 5 years of cannabis, 5 years of amphetamine, ecstasy, cocaine, opiates, and heroin. We found that the major one is cannabis, and the second one is amphetamine, and next is opiate, cocaine, ecstasy, and heroin. This is a 5 year 2000 until 2005 from UNODC report. Next is I'm trying to compare. I'm sorry, where's my screen? Okay, here. I'm trying to compare to the case we found from the UN. On that time we called UNDCP 2002, and right now is UNODC 2020. This is it is just only two main drugs that different. On that time, around 2002, it is equal between cocaine and opiate. But this year, recent year, we found the opioid or opiate is 2 times if compared with the cocaine. This is different, and it is confirmed 2 decades that major trafficking route, opiate and cocaine, came from Asia. So this is a trafficking route from Golden Triangle and Mid Asia, transit to transfer to other region. And if we focusing on only ASEAN region, this is the only ASEAN region that we found the major problem is amphetamine type, stimulant, ecstasy, cannabis, but opiate is not major if compare others drug type. This is a world report that we try to catch up. And if focusing on the major age group since 1980 until recent year, and forecast 20 to 50, we found that the major group problem is youth. Yes, the major drug user age group is youth. The age during 15 to 24, and surprising, we found the increasing in the elderly group and we try to monitoring about the prescription and opiate in this group. So it is not like it haven't more enough recent research in elderly and substance use disorder, but it is like a forecast in the age group over 15 years. What is lesson learned and key message found in the 2 decades? Sure, the first one is majority of the global illicit opium and methamphetamine production are in Asia. Oh, it is for 2 decades. It is major found. And the age demographic drug use are young people during 2 decades, you see. And addiction substance use disorder from the scientific paper said this is a chronic disease. So from the scientific paper said addiction as a chronic disease, it is a brain disease. And it means that characterized by compulsive drug seeking use despite harmful consequences. I catch up from the scientific paper. And during the 2 decades, found that the essence of SUD or substance use disorder, it is long-lasting brain change. This from scientific paper and uncontrollable compulsive drug craving seeking. I try to catch up from the treatment during the 2 decades. We found that it is outdated acute model care chain to provide with the successful treating complex disease, because this is the chronic and complex disease. So we need long-term care, not short-term care. But during the 2 decades, most of the program are short-term care. So what finding next? So I try to find out the successful of short term, but it is fail if compare long-term treatment. Long-term treatment is a higher possibility of successful if compared short term. So I found that the short-term treatment success rate after 1 year lesser than long-term treatment. Long-term is more success rate. And I try to follow the papers. Some people found that the continuum of care around 4 years is good. But from the scientific paper said that the immune will develop within 2 years. That is support the idea of long-term care than short-term care. This is from scientific paper. So this is the catch-up. Justly catch up the scientific paper, the drug monitoring, and the finding. I found a big challenge from the 2 decades. We should monitoring the aging society, because we are facing the aging societies, and the trend of aging society is prescription drug. So we are facing the new phenomenon with the elderly and substance use disorder. And the second one, substance use is a very serious disorder and complex disease that can be treated, but we can treat with the proper care and guidance and the proper support. So we found the appropriate care is holistic approach. It is not only treatment, but you should combine with the biopsychosocial. It means that together with the psychology and social security also. And how about the opportunity during the 2 decades? I think we found the paper said we have the social opportunity, academic opportunity, and financial opportunities. what is social opportunity? I think the opportunity for the research, we should make the research about the stigmatization, because right now we are facing the COVID-19 and lockdowns the city. We found that the stigmatization returned severe for the substance use disorder the client and their relative. So the stigmatization is one of major problem for the relapse. Another opportunity is social and welfare. Among developing countries, we need research about the social and welfare, how to support the long-term care, and how we revise laws and enforcement, because most of the client need treatment. He is not the criminal, but he is the client. So we need reform laws and enforcement. But we need more research support this opportunity. And the last one is about the partnership increasing demand in problem solving. This is the major opportunity in social opportunity that we need more research. What is the appropriate partnership? It is not only health harmful but social. So we need more partner, not only ministries of health that take more action, but we need the others department that collaborate of the problem solving. And next up, the opportunities or the research opportunity about the degree and non-degree in addiction study. Because right now we need addiction professional, but we didn't have more degree and non-degree in the university. So this is the needs of the university to develop degree and non-degree or postgrad degree and the university for conduct addiction professional of the field. Next is the standardized and addiction professional. We need the standardized and global standardized of addiction professional, because what is the standard for addiction medicine? What is the standard of the psychology and addiction, other addiction professional or peer professional, something like that. This is a standard that we need more evidence to show and develop the standardized. And next is internship opportunities. This is the opportunity for make the skill development. And exchange staff and student, this is more opportunity that we will learn more about the factors towards the treatment and prevention. If the student study and in another country, they will learn more about the factors influence the relapse prevention or others. And the last one is experienced guest lecturer, that this is opportunity to open worldwide for the lecturer learn more about the other factor toward the addiction. And the last one of financial opportunity. So as everyone know that we need more scholar and research grant to studies the many field in addiction that related, for example the medicines, or for example social, for example of nutrition. We need more field more evidence-based among diversity and addiction too. So we need more research and scholar. So this is a wrap up about the the finding that we found during the 2 decades. So let me turn on this slide. So I think I will,
thank you, Dr.
yeah, this is the okay. I would like to focusing on this slide. This is a trend. This is a trend that we monitor, that we forecast that the young people still use illicit drug. And surprising in elderly. So we need more research what happening in the future, and what is the policy, what is the I don't know. I think we need more research and we need more evidence to support to monitoring this 2 age group. This is I think this is a very important slide that we need to discuss in the future, but I cannot find the result to support why the young people still use. Just only the scientific said that this is the adolescent development, because this is the development of the biology, that this age group are like the group to easily to access the drug from his biology, and for the elderly, this group are based on the prescription. So just only paper point like biology related drug use, but the others I didn't see about why the young people still drug use among 2 or 3 decades. Just only like a resilient. If we develop resilience among this group, it may be solved problem, but we didn't have more evidence to support about the resilient much. Just only we found a lot of the AZE or like adverse child experience related the young people take drug, but we have failed papers. So this slide is very important for future studies. That is my talking and conclusion for opening today. Thank you.
And I also would like to thank you, Dr. Prapapun, for sharing this important information with us and raising such an important question. Thank you. And it is my honor to introduce our next speaker, Dr. Kristiana Siste, Head of Psychiatry Department, University of Indonesia. She has been practicing as an addiction psychiatrist for over a decade and was awarded a doctoral degree in medical science from the Faculty of Medicine, University Indonesia in 2019 for her work on mapping risk factors and fundamental connectivity changes among Indonesian adolescents with internet addiction. Currently, Dr. Kristiana Siste, head of Psychiatric Department at Dr. Cipto Mangunkusumo General Hospital, as well as its Division of Addiction Psychiatry. Dr. Kristiana, thank you so much for giving your time. I hand over to you.
So thank you, Dr. Olha. Sorry. Okay, thank you, Dr. Olha, and good afternoon, colleagues. Thank you for the nice introduction, Dr. Olha. Thank you for ISSUP and also ISSUP Indonesia, Dr. Dia, for this opportunity for me to share about epidemiology of substance use disorder before and after COVID-19 pandemic in Indonesia. So during this pandemic COVID-19, there is a big question. Is the pattern of substance use changing or not between before and after COVID-19? So we do national survey in Indonesia during this pandemic COVID-19. And this slide show us this is before COVID-19. Of course, we do the face-to-face session. This is a group therapy session for the people who use drugs, and this is very fun session, and it will be different among this pandemic COVID-19. And this slide shows us about the prevalence of drug usage in our country. So the past year prevalence is around 1.8%, means around 3.4 million adults or young people use drug in past year. Aged between 15 until 64 years old. And the problem is 0.25% of them was classified by drug use disorder. So it means around 10,000 people who using drug need treatment in service center. And how about youth population? So the prevalence is higher compared adult population. It's twice higher compared to adult population, especially in high schooler. And most of the people who use drug, they have polydrug substance use. Around 86% use more than 2 psychoactive substance, and around 0.5% use around 16 psychoactive substance. So it's very dangerous, and it's cause mortality and morbidity. And how about lifetime prevalence? It's around 2.4%. It means around 4.5 million adults have ever used substance once in their life. Sorry. And how about the types of drug abuse? So we can see here, the highest one is crystal methamphetamine. Around 90% of people use crystal methamphetamine. But there is interesting data. So we can see here around 50% of them use prescription drugs like dextromethorphan and also tramadol, and NPS synthetics like cannabinoid synthetic. So it's very interesting data because many people use prescription drugs now, and they get the prescription drug from illegal or a black market. And the second one is still marijuana. And this is in line with the report of National Narcotic Drugs and also national policy that the highest rank of drug user is crystal methamphetamine and also marijuana. And how about the prevalence of alcohol usage in our country? So the consumption of alcohol is still low in our country compared to global rates. It's around 3%. The people use or consume the alcohol, but twice of that there is heavy episodic drinking of the people. So they need attention because they tend to have alcohol disorder. And this is also interesting data. Around 60% drink unrecorded alcohol. What is unrecorded alcohol? That means counterfeit or fake alcohol. So the people in Indonesia usually combine methanol with local ingredients like energy drink. So it's very dangerous and cause death and morbidity also. And how about alcohol use disorder in our country? It's around 0.8%. So it's still low, but it's the third rank in Southeast Asia region. And the most common alcohol that consumed in Indonesia is wine and also beer. And this is the situation during COVID-19 in our country. So this is the situation in our hospital, National Referral Hospital, Cipto Mangunkusumo Hospital, and we wear the personal protection equipment there. And how about the strategy in Indonesia during this COVID-19? So the government has applied large-scale social restriction, or we call it PSBB. So the government closed all entertainment and also public entertainment and also like a public market. So the people has limited access to mobile from one region to the other region. And also the government prohibit that more people gather together. But the situation for substance use is very interesting because in June 2020, National Narcotic Board and National Policy found hundreds of kilograms of crystal methamphetamine. So it's very interesting. Is the pandemic COVID-19 affect the pattern of substance use in our country? And discuss about drug, we also discuss about trafficking and also routes. So in Indonesia, drug routes to Indonesia are mainly by air or sea. And during this pandemic COVID-19, government closed the air and sea port. So we are very curious, does it impact to the substance use in our country? And the slide in the right slide, this is from UNODC. UNODC try to do the pattern of trafficking drugs in Southeast Asia, and mostly of the the trafficking is from sea or air, except for opioid. And this is the response of UNODC, and they are also a big question: is there any impact of this situation for substance use? So many sea and airport are closed. Does it impact to the substance use pattern? So in May and July 2020, for 3 months, we do the national survey to see the pattern of drug abuse or drug use in our country. So we have around 7,000 participants, and it's come from all the region of Indonesia. And we can see here, cigarette use is increasing compared to before COVID-19. And alcohol use is decreasing compared to before COVID-19. And drug use is stable between before and after COVID-19. So this is also interesting data why cigarette is decreasing and alcohol is increasing. And this is the type of drug misuse during pandemic COVID-19. We compare the population between adolescent and adults. And also we can see here the interesting data. Prescription drug is the highest drug that adolescent and also adult use during COVID-19 pandemic, and also benzodiazepine. And there is significant difference between adolescent and adults when they are using benzodiazepine and stimulants. So we face the new problem and big problem for prescription drug abuse in our country. And we try to ask the perceived changes of substance use among the participants. So this is subjective perception among them, and then we get this data. So we can see here the people who use alcohol tend to increase the use of alcohol during pandemic COVID-19, but it's different with cigarette population. They try to decrease the use of cigarette. And for the drugs, around 30% of them increase the use and around 20% decrease the use, but most of them are stable in using drugs. So this is also interesting data why people tend to decrease the cigarette but try to increase the alcohol and also the drugs. And we try to analyze the data and the situation. So during COVID-19 pandemic, there is education about cigarette, that there is significant association between smoking and severe COVID-19 cases. So the people who use a cigarette try to reduce cigarette usage because they are afraid to get COVID-19 virus. And how about alcohol? So there is a hoax public education in our country, but Ministry of Health tried to reduce it, but still it widely spread. The hoax education is alcohol can kill the coronavirus, and I heard it also happened in other country like Iran. And why the people who use alcohol try to increase the usage? Because most of them use unrecorded alcohol or counterfeit alcohol. So it's easy to mix counterfeit alcohol at home. So they do not need to go to the supermarket or to a pub or to outside the house. They just mix at home. And we also try to identify the risk factor between the socio-demographic and the substance use disorder. And first, physical distancing actually associated with reduced cigarette and also drug usage. But how about PSBB or semi-lockdown that apply from our government? This is increased associated with this decreased smoking. And how about the companion? So people who living alone was associated with increased cigarette and alcohol consumption. So maybe they do not have a good support system, so they tend to increase cigarette and alcohol to reduce the psychological stress. And also income influence the smoking and alcohol usage. Low or lower middle income per month associated with lower smoking and alcohol usage because they don't have money to buy cigarette and also alcohol. And we try to identify other than socio-demographic. We try to identify the psychopathology. Psychopathology means emotional and behavioral disorder, and we use strength and difficulties questionnaire because it's among adolescents, and also Pittsburgh Sleep Quality Index for sleep quality. So we have finding the significant association among adolescents, but not significant association among adults. So we can see here the externalizing disorder, mean conduct, and hyperactivity disorder has significant association between with cigarette and alcohol consumption between two group use and do not use. So it means that the adolescent with conduct and hyperactivity disorder tend to use cigarette and tend to use alcohol. So maybe they have unstable emotional, so they have self-medication with using cigarette and alcohol. And also for prosocial behavior. Prosocial behavior means they have empathic behavior and they are willing to help others. So the adolescent with prosocial behavior tend to not use cigarette, alcohol, and also drugs. So this is like a prevention factor, not using drug. And how about sleep disorder? Sleep disorder, there is no significant correlation, but we found that people who use alcohol and also cigarette tend to have poor quality of sleep. So why we identify the risk factor? Because with identifying the risk factor, we can do a prevention strategy. Like maybe we can do early detection for adolescents to prevent them to use a drug during this pandemic COVID-19. So after we do national survey and we have the pattern of substance use among adolescents and also young people, so we need to do and develop strategy. And what about the strategy that we have applied in during this pandemic COVID-19? For response for response pandemic COVID-19, Ministry of Health and also Indonesian Psychiatric Association and also Ministry Council of Medical Doctor in Indonesia has developed many guidelines. This is the example. The Ministry of Health has developed guideline for substitution treatment, and also Indonesian Psychiatric Association try to develop a telemedicine guideline. So this is the our strategy. We use physical distancing and also protective equipment in service treatment, and also Indonesian Psychiatric Association recommend of telemedicine. So the patient can get the services from their home, and but this is exception for substitution treatment because they should come to the treatment for getting drugs. And also in inpatient facility, there is screening and also reduce the capacity by 50%. So this is the big problem also in our country. And for enhanced skill for the people in provide service treatment, we use online platform to update their skill. And this is also the example for adaptive addiction service. For maintenance therapy, the patient can have 3 until 7 days of take-home dose with maximal 500 milligrams. And also we do services for the people who use drug and then they have COVID-19 virus. They can be admitted to the national referral hospital or the other general hospital. So we also serve them in a general hospital. And then if they use methadone or buprenorphine, the family can bring methadone and buprenorphine every day to the hospital. And this is the example in this during COVID-19, there is physical distancing also. And this is the last picture. It shows a companion corner in general hospital. With this corner, the family can meet the patient by online or video call. So the patient can meet the family every day by online. And then this is the example of online training and services during COVID-19 pandemic. So we do also CBT online delivery. We try to develop online CBT delivery for the people who using drugs. So they just can stay at home, but we can do intensive counseling. And this is my last slide. I would like to define what is the challenges that we face now during pandemic COVID-19. So the first challenge is we know that the pattern has changed in Indonesia. The pattern of prescription drug is higher other than illicit drugs. So we need to have tailored approach based on empirical study. So we can develop the proper strategy to prevention until treatment. And also there is a problem with limited healthcare access and also funding, because there is a limited funding from our government. And then we need progressive national strategy and activate telemedicine infrastructure. So with telemedicine, the patient just stay at home and can get intensive psychotherapy or counseling. And also the government should have proactive education about rampant false news and also intensive counseling to reduce psychological stress among the people, especially the people who use drugs. And also we need to update or we need to develop novel universal substance use prevention program, because the pandemic is not end until now, and we do not know when will end. So we need a prevention program that fit with this condition. And also we need online or visual training and certification to update or enhance the skill for provider of a treatment center. So through this pandemic COVID-19, it's a dark situation, but we will sure that we will get through this situation and seeing every challenge and opportunity to better serve others, including us, the people who provide the service treatment for the people who using drug. So thank you so much for your attention. Thank you, Dr.
Thank you.
Olha.
And we thank you, Dr. Kristiana, for your great input into our webinar. Thank you. Dear colleagues, we are moving forward, and I'm moving on our next speaker. I would like to introduce you Dr. Maria Prilutskaya, psychiatrist, assistant professor at Semi Medical University, Kazakhstan. She has worked at drug addiction hospital since 2008, and the sphere of her professional interest is new psychoactive substances. The topic of her PhD thesis was also related to epidemiological and clinical aspects of new psychoactive substances in Kazakhstan. Dr. Maria, we appreciate much for you being with us today, and I hand over to you.
Thank you so much, colleagues. I tried to be as short as possible, considering our boundaries, time boundaries, and schedule. So, dear colleagues, thank you for this opportunity to take part in this meeting as a panelist, presenting our main trends and tendencies in ever-changing situation regarding drugs in Kazakhstan. Kazakhstan is a country of Central Asia region that has been facing predominantly the issue of opioids and cannabis traffic over the 90s and 2000s. But 2009 saw the first media reports followed by police reports on the emergence of NPS on the illegal drug market. And by 2016, 58 NPS had been identified in Central Asia region, when 2/3 of these drugs were seized in Kazakhstan. A rising number of online vendors within social networks and on the dark web reflected the growth of NPS supply capacity. For example, according to the drug stat study, Kazakhstan transaction accounted for $3 million of Hydra revenues in 2019, compared to $990,000 in 2018. Methadone and alpha CBT as a stimulant of synthetic catenon groups substantially dominated our drug market. In parallel, the number of patients suffering from NPS abuse has increased at our drug addiction clinics over a 3-year period, from, and you could see here, from about 4% to just more than 10% in 2018. Remarkably, not all regions of Kazakhstan have equal distribution of NPS patients. For example, northern and northeastern regions have with immense borders, immense markets with China and Russia, had considerably higher rates of clinical admission due to NPS abuse. Remarkably, we revealed that half of the NPS addicted patients combine synthetic drugs with traditional drugs. Patients reported the combination of synthetic catenols with traditional opioids in a fifth of the cases, and synthetic cannabinoids in a third of the cases. And 1/3 part of stimulant user reported parenteral routes of drug administration, including binging form of narcotization. The national legal system of NPS schedule has developed over a 9-year period, resulting in the prohibition of more than 100 harmful diverse NPS. And the current legal approach addressing NPS could be classified as generic, where our legal schedule boards considered these NPS according to and schedule them according to their chemical structures and relevance to the parental molecules. The new trends of the illegal drug market have called for the studies of drug use prevalence among, of course, youth population in Kazakhstan. Furthermore, the last available survey data regarding NPS regarding this population did not include NPS questions. And we could see here in this slide, we could see that lifetime prevalence of synthetic drugs in 2012 were no more than 1%, except in DMA. And we take all of these into consideration, and we start a project that called Epidemiological Portrait of NPS, pilot investigative research. This project was carried out in 2019. The data were obtained with the survey that was conducted in all 17 big cities of Kazakhstan. The target population was young people aged from 18 to 34, and we used quarter sampling, and sample size was set up at 1,500 respondents. And in social demographic characteristic, we revealed only gender and age differences. And you could see here that the age group of age between 25 and 29 were more likely to experience in their life NPS use at least once. And just about half of the respondents were aware of NPS by various street names. And the most prevalent were spices, for synthetic catenones, and scorest for synthetic catenones. And 1/3 reported having at least one person in their immediate circle with this NPS using behavior. The NPS using respondents were about 8 times more likely to have NPS using friends comparing to their counterparts. Within the survey, 11.7% of respondents reported having used any illicit drug except NPS, and 6.3% used NPS at least once in their lifetime. The most prevalent drugs were, of course, synthetic cannabinoids and synthetic catenones in the age group of 25-29. But MDMA and fentanyls were also identified in the survey. Like in the hospital samples, we could see the regional structure of all respondents were not equal. For example, we have stimulants, but at the capital we have more prevalence of synthetic stimulants. Yes. And the absolute majority of NPS using young people bought the drugs through the internet, using online vendors, using social networks, drug forums, dark web markets. And respondents reported traditional drug use considerably more often. And the tendency was relevant for both prevalent and sporadically presented markets. And what we could see with logistic regression, our analysis confirmed this association between marijuana, amphetamines, inhalant sedatives, tobacco use, and actually multi-drug usage with NPS use. And a wide range of clinical symptoms were identified, described by our respondents, including neurological symptoms in a long period of time, even in post-intoxication period. And in the form of final question, very interesting actual question, we ask our respondents to consider, to estimate the relevance of different motives for NPS use, not among them, but also among all Kazakhstan population. And notably, NPS using respondents were more likely to regard price, availability, and the legality as important motives for NPS use. So the main findings of our study and our first steps in the studying of this prevalence, of course, are this high prevalence and actually an equal prevalence in lifetime use, both in patients in hospital-based population and our young people. Men in both samples were about 2.5 times as likely as women to use NPS. Synthetic cannabinoids prevailed among other NPS groups, and 2/3 of NPS using respondents bought NPS through internet forums. And cannabis, amphetamine, inhalants, sedatives were directly associated with NPS use. And we have in clinical symptoms various different symptoms, from psychotic symptoms to asthenic symptoms, neurological post-intoxication signs. And NPS users were more likely to consider NPS as empathogenic agent, favoring them for their legality, availability, and low price. That were our main results, our preliminary first results, and of course, we are focused on the idea to continue this surveying process. Of course, considering all the shortages and challenges of the COVID pandemic situation. Thank you so much for the presentation, for your attention.
Let me thank you, Maria, for the fascinating insight with new psychoactive substances. And moving on, it is my honor to introduce you our next speaker, Saima Asghar, social worker, director of ISSUP Pakistan National Chapter, Executive Director of New Life Rehab Center, Sialkot, Pakistan, for substance use disorder prevention, treatment, and rehabilitation. She conducted several awareness raising sessions on health and lead many substance use disorder prevention and treatment campaigns in educational institutes and communities. Thank you, Ms. Saima, for being with us. I hand over to you.
Good afternoon, everyone. Let me show. Good afternoon, everyone. Thank you, Dr. Roland, ISSUP Global, and ISSUP Pakistan for providing us this opportunity. Today, I'm going to talk about the prevalence of SUD in Pakistan over the past 2 decades, and we'll share some new tendencies and new substances. This is an overview of my today's presentation. First, I will talk about First, I will give you a brief background about substance use problem. It will help to understand the overall scenario. And then I will talk about the prevalence of SUD in Pakistan. And after that, we will see some new tendencies and new substances, most specifically with reference to the past 2 decades. Let me show you the map. Pakistan, let me show you the map. Pakistan is bordered by India on the east, the Arabian Sea on the south, Iran on the southwest, Afghanistan on the west and north, and in the northeast is China. Islamabad is the capital city and Karachi is the largest city of Pakistan. Actually, Pakistan sits one of the world's busiest drug trafficking corridor, largely due to the cultivation of opium poppy and cannabis in neighboring Afghanistan. Drug production in Afghanistan. According to UNODC estimates, Afghanistan produces 60 to 70% of world supply of illicit opioids and more than 45% of drugs like heroin and cannabis produced in Afghanistan and routed through Pakistan to destinations in Europe, Asia, and some extent Africa and North America via KPK, Balochistan, Iran, seaport of Karachi, and Port Qasim. This generates a considerable opioid supply for export, but also for domestic use other than cannabis and opium poppy. Here is a background. Asia is a densely populated continent with great ethnic and cultural diversity. Among the 14 countries are areas in the world with serious narcotic problems. 6 are in the Southeast Asia, but the information available on drug abuse and the problems associated with it in Asian countries is in most instances inadequate and fragmentary, and Pakistan has no exception. As the manufacturing and availability of drugs are increasing in Asian societies, same is directly affecting on prevalence and new trends in use of abusive drugs. These new emerging phenomena made challenges to everyone, but unfortunately, many Asian countries do not have the data infrastructure to generate reliable estimates of drug use, especially when it comes to substance use disorder. Most countries rely on surveys of self-reported behaviors to learn about the substance use in general population, and issues of underreporting might be more pronounced in Asia compared with other regions, and given greater stigmatization and harsh punitive responses. According to UNODC 2016 report, most countries in Asia irregularly reports the results of household and school surveys, and according to ASEAN Regional Drug Report 2016, many countries in Asia do not collect data on a regular basis. Due to this irregularity in collecting and reporting reliable data, it is difficult to figure out the exact prevalence rate of SUD in such countries. These are some commonly abused drugs like cannabis, opium, heroin, amphetamines, cocaine, and pharmaceuticals. Actually, the use of illicit drugs and non-medical use of prescription drugs are established and widely recognized phenomena in Pakistan. Cannabis is not only the most abused drug in the region, but also in Pakistan. Apart from cannabis, amphetamine and methamphetamine are the most commonly used substances. Now I'm going to share the prevalence of SUD in Pakistan. According to UNODC, Pakistan is one of the countries hardest hit by narcotics abuse in the world. In the recent published paper in Express Tribune 2017, found that about 8 million drug users of different kinds, growing on the annual rate of 7% in Pakistan. An examination of social and demographic factors revealed that more than 71% of the drug users were less than 35 years of the age, with the highest proportion in the 20 to 30 years of age group. And according to UNDC, cannabis is the most commonly used drug with a prevalence rate of 3.6 of the population, equivalent to 4 million users nationwide. According to UNODC 2013, poly drug use is common, with one of the 5 reporting more than one controlled substance use in past year. An estimated 860,000 or 0.8% of the population are regular heroin users, and 320,000 or 0.3% are opium users. Combined, 1.06 million people are 1.0% of the population aged 15 to 64 years are using opiates. And the majority of drug users in this study fell between 25 and 39 years of age. Cannabis use was highest among 30 to 34 years old, and heroin use was highest among 35 to 39 years old age group. Previously undetected in the country, trace levels of methamphetamine are now being reported with around 19,000 people estimated to have used this stimulant last year. The number of people who inject drugs is estimated to be 430,000 nationwide, or 0.4% of the population. According to Express Tribune 2018, this paper further suggests that about 700 people die daily due to drug abuse caused complication in Pakistan. Of all the drug users, almost 50% were illiterate, and surprisingly similar percentages were the employed. And according to the Narcotics Control Division, among occupational categories, the frequency of drug use was highest, like 50.8% for those in skilled and unskilled labor categories, followed by the sale is 16.8%, and agriculture is 75%. Also, students are 7.4%. An examination of social and demographic factors revealed that 71% of the drug abusers were less than 35 years of age, with the highest proportion in the 20 to 30 years of age group. Over the past 2 decades, the use of drugs among youth in and out of school has been increasing worldwide. Such use may in most cases be classified as experimentation with drugs. The use of tobacco and alcohol is generally acceptable for older students, but not for the younger students. Now I'm going to share the drug use among women. Is it a low prevalence or hidden? According to UNODC 2010 report, and based on the 50,000 household interviews, women constitute 25% of the total population of drug users in Pakistan. In any case, drug use among women in Pakistan is not common. However, the study itself questions the accuracy of the number. While men were found to use more drugs than women for most drug types, women are more likely to misuse tranquilizers and sedatives as well as amphetamines in Pakistan. And according to UNODC 2013 report, among the dependent users, women were less likely to have received treatment than men. Here I'm going to share some SUD problem with youth in Pakistan. In Pakistan, the youth comprise more than 20% of the population, and unfortunately, they are the worst target. According to Newsline 2018, A recent survey conducted in an affluent class of Karachi shows that almost 90% of the boys belonging to the elite class as young as 10 years old and admit to having experimented with drugs and drink, if not sex, at some points of their lives. And approximately 4 in 10 indulge themselves regularly, and approximately 30 to 50% of the girls attending the city's top private schools have experienced a drug-induced high, most commonly on dope. These are some numbers describing the trends of substance use in Pakistan. Like here is the table that shows the name of the drug, percentage, and estimated users. Any illicit drug is 5.8%, and 6.4 million users are in Pakistan. Cannabis is 3.6%, and under 4 million users are in Pakistan. Heroin is also 0.7%, and 8,13,000 are users, estimated users. The opioid is 2%, and the estimated users are 2.7 million. All opioids, sedatives are 1.4%, and the estimated users are 1.5 million. Injecting drug use is 0.4%, and estimated users are 4,23,000. There are some numbers related to demographic information of the person with SUD, the types of illicit drugs, and their age ranges. Painkillers, sedatives, and tranquilizers are mostly used 15 to 16 years of the age group. Cannabis, like hash and marijuana, 20 to 29 years of age group. Opium is 40 to 44 years of age group, and heroin is 30 to 34 years of age group. Now I'm going to share some new tendencies and new substances. Apart of cannabis, amphetamine and methamphetamine are most commonly used substances. Recent Siste data reveals that 2 types of methamphetamine are being used in the country. First is the crystal meth called shisha adari, that means glass pen, and the second is tablet. E-cigarette, a battery operated device, is used an alternative to traditional smoking, are getting popularity in Pakistan. The use of these synthetic stimulants has surpassed use of more traditional plant-based drugs such as opiates. And according to ASEAN Drug Monitoring Report 2017, amphetamine-type stimulants, namely methamphetamine, are going concern in recent times. More than 50% of the total entered for the treatment in 2017 and were being treated for ATSs, like amphetamine-type stimulants. And thank you all for your attention. And before I end my presentation, I would like to thank ISSUP Global. And I would also like to appreciate our forces like Anti-Narcotics Force Pakistan and Narcotics Control Division Pakistan for their efforts to eliminate drug abuse, to eliminate SUD from Pakistan and all over the world. And thank you, ISSUP Global, and thank you everyone for your attention. Thank you.
Thank you, Ms. Saima. Thank you very much for your contribution into our event. We're a little bit out of time, so now I move on to present to the presentations that came on from Philippines. And I would like to introduce Maria Regina Hershanova Alampai, a full professor and licensed psychologist and the chief of party of the USA Renew Health Project. Regina was formerly the chair of the Department of Psychology at Ateneo de Manila University and past president of the Psychological Association of the Philippines. A prolific researcher, Gina was named one of the outstanding young scientists in 2005. Thank you, Dr. Maria Regina. We welcome you.
Thank you all. First of all, I'd like to thank ISSUP for the opportunity to speak to you. I'd also like to give a shout out to ISSUP Philippines and our president, Chit Castillo, who happens to be celebrating her birthday today. Okay, so you can see my slides, right?
Yes, yes. Thank you.
Yes, all right. So I'm going to begin with describing the client flow for how drug treatment is in our country. You might have heard that in 2016, our government waged a war against drugs, and that resulted in about 1.3 million drug users who voluntarily surrendered for treatment. Now, this is the client flow that we follow. It shows that there are two routes: for voluntary surrenderies to go through screening, and those who are low and moderate risk can be treated in the community, whereas those who are incarcerated because of drug use and are court orders needs to go through another route through drug dependency assessment by doctors. And depending on their level of risk, clients can go through either community-based or outpatient or inpatient or psychiatric treatment. So this is the context for my talk today. In our recent household survey by the Dangerous Drugs Board, they report that prevalence is about 2%, or about 2 million Filipinos. This is a slight decrease from its 2015 survey findings, but we're really at that range, about 2%. And as you can see from our findings, about 86% are low to moderate risk, which means that they can be treated outside in the level of community. However, you can also see that beyond drugs, alcohol and smoking dependence is actually slightly bigger. The drug of choice in the Philippines is cannabis, followed by methamphetamine chloride. In general, our users are young, similar to other countries. There's also a link, our studies show a link between drug use and mental health. And as you can see here, the lower risk drug users, the prevalence of mental health risk is only about 19%. But as you go higher, the proportion of those who have mental health risk also increases. Similar to other countries, the ratio of male to female is about 1:9, so 9 males, 10% females. Our drug users tend to be undereducated, as well as unemployed or underemployed. Now, for the past 4 years, since the war against drug was declared, there was really a big push for drug demand reduction. And one of the drivers for community-based drug recovery in the Philippines was the assistance of many international organizations, including ISSUP. There are also a number of local government units that really embraced community-based drug rehabilitation in its truest forms. And because the Philippines does not have a history of community-based drug rehabilitation, many of our civil society organizations, our faith-based, our professional organizations stepped up and began assisting local government units. Because of COVID in the past months, we've also noticed the emergence of virtual CBDR and even online Narcotics Anonymous meetings. And there has been some evidence-based programs that have emerged. So I wanted to tell you a little bit about our own journey. So I was part of a team that helped initially one local government unit, and we began with a needs analysis of what were the predictors of use and dependence. We did surveys and we did regression analysis, and we found, similar to what the other speakers have shared, is that alcohol and smoking were gateway drugs. Recovery skills was a
significant predictor of both severity of use and dependence, and of course, mental health risk. But beyond these four main predictors or direct predictors, we also found indirect predictors. So for example, life skills and the quality of life affected mental health, which in turn affects severity of use. We also found differences in predictors by risk level. So for example, for low risk users, it was really alcohol and smoking that predicted use. For moderate risk users, it was recovery skills and mental health. And for high risk users, it was mental health. That was the most significant predictor. Based on these findings, we helped a local government unit develop a community-based drug rehabilitation program for moderate risk clients. And the program consisted of drug recovery skills, it consisted of life skills, it also consisted of family programs, because in the Philippines, the culture is that the family is an important recovery capital. It's also a risk factor, but it's very important for recovery. Because of the lack of personnel, as well as the lack of resources and the collectivist culture, we created a program that was group-based, that was structured, and we pilot tested this. We were happy to see improvements in recovery skills, in life skills, as well as a decrease in substance use dependence symptoms. So this program eventually was adopted in other local government units as well. And although we have had some gains for the past 4 years, we have had a lot of challenges as well. So for example, other speakers have also mentioned stigma and discrimination. In the Philippines, there is still a large tendency to view drug use as a crime rather than as a health issue. At the beginning of this whole community-based drug rehabilitation, a lot of local government units were using very lengthy one-size-fits-all programs that were really more appropriate for dependents, but not low and moderate risk users. We also found that because there was a lack of resources and capacity, local government units were doing all sorts of things like diversion programs, Zumba, physical exercise and all of that in lieu of real treatment. It doesn't help that there's really no formal education or addiction sciences in the country. And so we are happy for institutions like ISSUP who do provide regular training and certification. Of course, COVID, like the rest of the world, has affected very much delivery of services. Sad to say that despite the gains, we are still at a point where service provision is really quite low. So for example, our estimate among our project sites right now is that only less than 50% of the clients have actually been screened, and less than 20% have actually completed treatment. And there are a number of challenges, whether it's transportation or lack of access or time or schedule, that are barriers to treatment. Having said that, we believe that there's a lot of hope for the country in terms of institutionalizing community-based drug rehabilitation. So I'm very honored to be part of a USAID project whose goal is to expand access to community-based drug rehabilitation. And the way that we see our challenge ahead is in terms of three things. How do we scale up? How do we ensure its sustainability? And how do we change the culture? Okay, so to our minds, the most important road ahead would be, one, to reach clients and their families, to take away the stigma and position drug use as a health issue. Okay? But in terms of service delivery, it's very important for us to be able to remove the bottlenecks that are currently in place in terms of screening. So part of our project is the translation, adaptation, and even automation of technology to aid screening, as well as capacity building. Currently, much of the screening is being done at the local government unit, but our dream is to be able to screen as per our client flow, is to be able to screen in schools, in hospitals, in workplaces as well. In terms of treatment, the challenge is to really scale up evidence-based treatment and enable delivery of treatment in various modalities given COVID. So from face-to-face to blended to even online treatment. We also have some problems with regards to service delivery in terms of the entire network from end to end. And so what we really need to be able to do better is to map out referral services for recovery support and for aftercare. And then, of course, we think it's very important to make sure that community-based drug rehabilitation is institutionalized no matter who is in government. And so it's important for some changes in our policies, in our structures, in our budgets, personnel, and we do hope that soon we will have more formal education or even licensure in place for addiction sciences in the country. More importantly, we feel that the biggest challenge ahead is really to shift the governance of drug use treatment or drug treatment from peace and order. Right now, a lot of the people handling drug treatment in the communities are based in peace and order clusters rather than in health clusters. So shifting sort of the responsibility and the scope of drug treatment to health professionals is very important. So looking at drug use not only from inpatient, but also from a public health perspective. Thank you.
And thank you, Dr. Maria Regina. Thank you so much for your input into our webinar and for giving your time. And dear colleagues, we prepared a surprise for you, and we have one more speaker from ISSUP India. And it is my honor to introduce to you Dr. Alok Agrawal, Associate Professor at All India Institute of Medical Science, New Delhi. And Dr. Alok has a great experience in expertise in the broad area of addiction psychiatry, with particular emphasis on epidemiology of substance use disorders. Dr. Alok, thank you for joining us today. I hand over to you.
Thanks a lot, Olha. I hope I'm audible to everyone. First of all, I would like to thank ISSUP for inviting me to be part of this initiative and also accommodating me at the very last moment. So thanks a lot for that. Now, what I'm going to speak about is the current status of or understanding of drug use epidemiology in India. And as we all know that India is a very large and diverse country, and also has a very long history dating back thousands of years. So drug use has also been a part and parcel of the fabric of the society for a very long time. And various forms of substance use have been recorded in our history through the years. And the drug use was fairly widespread, especially when we consider tobacco, alcohol, and cannabis, and opioids. But it was largely use of low potency products, and the prevalence of addiction was not documented to be very high. And there was some degree of socio-cultural sanction to the use of substances, as well as regulation of the use of these substances by the society. And in many ways, one can see drug use as a part of, I mean, as a way of life in the society. However, there were changes in the pattern of substance use over the years, especially after independence. There have been significant changes in the way substances are consumed in our country. And especially in the last 2 or 3 decades of the previous century, a number of changes occurred. To some extent, there was westernization of the overall society, as well as gradual normalization of alcoholic beverages, especially in urban centers of the country. Then, under international obligations as well as pressure, India introduced a very draconian law which prohibited all forms of substance use except alcohol and tobacco in the country, and also introduced very strict penal measures for even possession or consumption of substances. This law was introduced in 1985, and this basically coincided with introduction of high potency processed opioids like heroin in the country, and also emergence of injecting drug use in certain parts of the country. So after that, there have been certain changes in the drug use epidemiology of the country, and also there has been an increasing availability of pharmaceutical products which can be used for recreational purposes, particularly opioids. So it was in this scenario that India conducted its first national survey on extent and pattern of substance use in the country. And the survey was, the data for the survey was collected in 2000-2001, and the report was published in 2004. So this was a government commissioned survey conducted in collaboration with the United Nations Office on Drugs and Crime, Regional Office of South Asia, and and All India Institute of Medical Sciences, the institution I come from. So the survey included a national household survey among males between the ages of 12 and 60 years, and also took data from treatment centers. There were some small studies conducted on specific themes or specific populations, like street populations or people living in border areas. So in 2004, when the report was released, the key findings from this survey was that for almost all substances were identified as being used in the country. Of course, the most prevalent ones were alcohol, cannabis, and opiates. And this, because the country's population is so large, this also meant that there were a large number of users of these substances in the country. Almost 70 or 80 million users were identified, estimated, and about 1/4 of them were actually dependent users. So there were almost 12 million dependent users for various substances in the country at that point in time. However, the survey was criticized for a variety of reasons, particularly for its methodology, because it chose to only conduct a household survey, which is a form of representative population-based estimation method. And the sample only included males and only provided national estimates, which were not very useful for a large country and diverse country like India. And because of the use of only household survey, there was possibility of underreporting of use of illicit drugs in particular, because there is a lot of stigma as well as legal implications associated with reporting their use. So it was believed that while the survey did provide some useful information and a glimpse of what the scenario was with regards to substances at the time, there were major limitations with regards to its methodology, especially with respect to use of illicit drugs. Now, this was about 20 years back. Since then, there were multiple attempts to conduct another national survey, but somehow it did not materialize. However, a number of academic institutions conducted smaller studies. They were either limited to one district or one site, or maybe sometimes one state. But these studies, although did provide some useful data, they were not really studies done with representative samples. So the findings of these studies were not generalizable. There was one large scale study conducted among substance using children, and this study was commissioned by National Commission on Protection of Child Rights. And in this study, again, this study was not really meant for estimation of the size of substance use among children, but rather it provided some data on the profile of children who use drugs. And it reported that almost half of those children consume alcohol and about 1/3 use inhalants. So it was basically there was a point in time where there were no recent national estimates available for India, and we represent 1/6 of the entire population of the world. So it also affected estimations for at the global level, and that is why in World Drug reports, for about 7 or 8 World Drug reports between I think 2010 and 2019, the row for India was left blank in absence of any recent data, which was fairly embarrassing for the country as well. And that's why Government of India then in 2016 decided to commission another national survey, and the responsibility for which was given to, again, All India Institute of Medical Sciences. And this was a survey which was started in 2017 and was part of it finished in 2019, and the report is now available. And it was a very large, ambitious scientific exploration of the epidemiology of drug use in the country, involving a number of academic institutions as well as organizations already working with drug using populations. And the data for this survey was collected between the age group of 10 to 75 years, and this time around it included females as well. And all substances except tobacco were studied as part of this survey. Because so many field teams were involved in data collection, there was some amount of standardization of training material and training methodology which was attempted to ensure quality of data collection. And all the ethical aspects, especially when you are studying a phenomenon like drug use, we tried to take them into account. Now, this survey tried to address some of the limitations of the previous one, and that's why it used multiple methodologies. So not just probability-based sampling like household survey, but it also used indirect methods of estimation, non-probability-based sampling techniques like respondent-driven sampling surveys for illicit drug use and use of rarer drugs. And then there were some other components of the survey which are still ongoing. Of course, COVID-related restrictions have affected data collection in the last 6 months, but we do hope that in the next 6 months we'll be able to finish the rest of them. So today I'm going to focus on the findings of the two major components of the survey, the household sample survey and the respondent-driven sampling survey, which also were the two components which provided us with the estimates of substance using population. Now, as far as the household survey is concerned, we used a multi-stage sampling procedure with probability proportionate to size, and it was conducted in all 36 states and union territories of the country. And 186 out of 640 districts were covered in the household survey. And we surveyed more than 200,000 households and interviewed almost 500,000 individuals. As far as the survey among users of illicit drug is concerned, the respondent-driven sampling survey was conducted in 34 states and UTs. We could not conduct it in 2 union territories because of operational reasons. It covered 135 districts, and we interviewed more than 72,000 drug-dependent individuals as part of this component of the national survey. Now, I'll discuss the results of this large epidemiological study, but just to give you an idea of the terminology is used here. When we say current use for any substance, we are referring to any use within the past 12 months. We have also tried to understand the prevalence of harmful use and dependence for each of the drugs, and for that we use WHO assist as a reflector of severity of usage, and the dependence basically refers to a WHO assist score of more than 26 for any given category. We use the term quantum of work, which is basically refers to use disorders for any given category of substance, so includes harmful use and dependence. When I say prevalence, it is actually a weighted prevalence and not just the prevalence among surveyed individuals. So it is extrapolated to the population of this state and country. And wherever I give numbers, those numbers are based on the projected population of the country in 2018. The last census was conducted in 2011. So based on decadal growth rate, we projected the population for 2018, and that's how we have derived the numbers. So I'll be discussing the results category-wise, beginning with alcohol. Now, as far as alcohol is concerned, we found that about 15% of the population of the country has used alcohol in the past year, which is about 160 million individuals, and about 1/5 of them are actually dependent users, almost 30 million. And there are another about 28 million users who are actually harmful users of alcohol. So while the prevalence of alcohol use itself is not very high, the prevalence of problematic use, alcohol use disorders, is fairly high. One of the one of the opinions that is prevalent in our country is that the use of alcohol is increasing among females. What we found in the survey is that the ratio of women to man alcohol users was 1:17, and so the prevalence of alcohol use among females is still fairly low. In fact, if we look at different population subgroups, what we find is that among males and among adults, the prevalence is higher, and among females and children, the prevalence is fairly low. So alcohol use in our country still remains largely an adult male phenomenon. Another interesting finding from our survey was that we looked at the type of alcoholic beverage that people consume. And what we found is that about 2/3 of alcohol users prefer to take high concentration alcoholic beverages like spirits or something known in India as country made liquor, which is similar to rum in its preparation. And the use of wines and beers, lower concentration alcoholic beverages, is rather limited. And this actually is then reflected in some of the other findings, like we found almost half of alcohol users qualify criteria for WHO heavy episodic drinking. Almost a fourth of them have been involved in physical fights under influence of alcohol. So some of these are a reflection of choice of alcoholic beverages which is high concentration. Now, as far as prevalence of alcohol use in India is concerned, it appears that it has largely remained stable over the years. In the previous national survey, the prevalence was 21% among males. In this survey, it is about 27%. So there hasn't been a lot of change. But what we see is that in India, as compared to the world, WHO estimates that about 43% of people above the age of 15 have used alcohol, are current users of alcohol, and the prevalence of alcohol use disorders is about 5%. In India, the prevalence of alcohol use is about 1/3, but the prevalence of alcohol use disorders is still similar. So this indicates that in India, people who use alcohol tend to use alcohol more heavily and are at greater risk of going on to develop alcohol use disorders. So this probably reflects on the way alcohol consumption is seen in our country. It is still, most of the population are lifetime abstainers. Alcohol use also to some extent is stigmatized. So probably people who drink, they also tend to then get drunk, because drinking and drunkenness, they carry almost the same level of stigma within the society. Now, what we also then see is that if you look at different regions of the world, you find that in Western and more developed regions, the choice of alcoholic beverage, high concentration alcoholic beverages like spirits, it is roughly 1/4 to 1/3. While in India, almost 2/3 choose high concentration alcoholic beverages like spirits. So that was another difference that we noticed as compared to other areas of the world. However, it is similar to the South Asia region. This is fairly, common to all countries of South Asia, the choice of high concentration alcoholic beverages. Coming to cannabis, what we found for cannabis is that there are about 3% of the population has used cannabis, and about 1 in 12 are dependent on cannabis. What we also looked at is the two categories of cannabis in India. One form of cannabis, bhang, is actually legally available, and illicit cannabis like marijuana and hashish is also prevalent. So what we found is that for illicit cannabis, the prevalence is about 1.2%. Once again, like in case of alcohol, cannabis use also is largely a adult male phenomenon in India. And if we compare it with the rest of the world, what we found is that the prevalence of illicit cannabis is about 1/3 as compared to other parts of the world. Now, opioids, we found that about 2% of the population has used opioid. We also looked at the subcategories of opioids, which is traditional opioids like opium, and processed opioids like heroin, and pharmaceutical opioids. So in India, the largest subcategory of opioid which is used is now heroin, followed by pharmaceutical opioids, and then opium. So this is actually a change over the previous survey. In previous survey, opium was about 2.5 times that of heroin, and now heroin is prevalence is about 2.5 times that of opium. So the ratio has reversed. If you look at the prevalence of India with and compare it with the rest of the world, you find that in India, opioid prevalence is about 3 times as compared to the world prevalence. Now, coming to inhalant use, about 0.7% of the population had used inhalants, and this was the only category of substances in which the prevalence among children was almost 2 times that of adults, which is basically what one would expect. Now, when it comes to use of other substances, these are traditionally considered not to be very prevalent in our country. And in this survey also what we found is that both use as well as use disorders were very, very small as compared to the other categories of substances. And if we compare the data for cocaine and ATS with the rest of the world, what we find is that for both cocaine and ATS, the prevalence in India is much lower as compared to the world prevalence. Now, coming to injecting drug use, we estimated that there are about 0.85 million, almost 1 million injecting drug users in our country. And we looked at the injecting practices and we found that heroin and a pharmaceutical opioid known as buprenorphine, they are the most preferred drugs for injecting drug use. ATS and other pharmaceutical products, they are not really that prevalent in our country when it comes to injecting drug use. It's largely dominated by opioids. One of the most disappointing findings of this national survey was the level of access to care for those who are affected by substance use disorders. So if we look at alcohol dependence, what we found is that only 1/4 of those who tried to quit received any medical care, and the number of people who received medical care, only 1/5 of them received inpatient medical care. And the situation for illicit drugs was slightly better, but not really very satisfactory. So the access to care, medical care, quality medical care, or evidence-based treatments remains very, very low. The impact of this survey and the findings of this survey at the global level was also felt in the most recent UNODC World Drug Report. The estimations for opiate and opioid users have increased by about 56% as a result of the surveys from India and Nigeria. So these findings have had global implications as far as the estimates for illicit drug use is concerned. Just to summarize, substance use is a huge issue and substance use disorders are a huge issue in India. Although the prevalence is low, but because of the large population, the numbers of people affected by substance use disorders is enormous. The prevalence of opioid use is higher than the rest of the world, while the prevalence of cannabis is lower. The worrying trend is increasing prevalence of high-potency opioids and injecting drug use. The penetration of stimulants and other newer preparations like synthetic cannabinoids is still fairly low. The access to treatment programs is extremely limited, and of course, things may have changed in the last 6 months with all the COVID restrictions, and there is a need to study the impact of those restrictions on drug use epidemiology in the country. Thank you very much.
Thank you, Dr. Alec, for joining us today and for your presentation. And also, I would like to thank everyone for participating in our joint webinar and our speakers for their great contribution to this event. Also, I would like to say thank you to Olivia Woodrow for her continued technical support of today's event. We do appreciate much your support, Olivia. Given the time constraints, always too much good input and not enough time to provide it. We are sorry, but we need to remove our Q&A session. But I can please ask that you email us with your questions and to whom you want us to send them to, and then we can pass questions into the relevant speaker and hopefully provide responses. I would like to remind that the webinar will be available online at the ISSUP YouTube channel and on our website on the ISSUP website knowledge share. And Olivia will share the link in the chat with you. We also invite all of you to become ISSUP members if you're not already, so you could become a part of our group. Please join at www.issup.org. Thank you so much for your time and attendance. With so much valuable and expert input, I hope you find it all of value. Thank you again for our eminent contributors and looking forward to meet you soon on the next ISSUP event. And always feel free to contact me with any questions.
Thank
Thank you.
you.
Thank you,
Thank
Dr.
you.
Ola.
Yeah,
Thank
and
you.
Thank you
Thank
so
you.
much.
Bye.
goodbye.
Bye-bye.
Bye.
Bye, everyone.
Goodbye.